Hello and welcome to the Trust Driven Podcast. Today is Trivia Day, where we strive to make medical communication research not only informational, but fun. So today I'd like to introduce our guest that will be playing trivia with us. Returning, we have Amanda Satterlee. She is a chiropractic radiologist from Las Vegas, Nevada. We also have Dwayne Golbeck. He is a chiropractor from Katusa, Oklahoma. And Maria Naidig, and she is a registered nurse and patient advocate in Columbus, Georgia. And Maria is coming back from a near win last week. So hopefully she's going to jump ahead and we'll see how we do. All right, let's get started. Okay, question number 1. The article title here is Assessing Effective Physician-Patient Communication Skills. Are you listening to me, Doc? It's by Anthony Berman, and it was published in the Korean Journal of Medical Education in 2016. So your question today is, an effective introduction does what for the patient? So your answers are A, makes them happy, B, reduces anxiety, or C, confuses them. So if your introduction to a patient is effective, is it going to make them happy, reduce some anxiety, or cause some confusion? Well, I'm going to jump out there and say I really hope that we're not causing confusion when we give a good introduction to our patients. All right, you guys got a couple more seconds. All right, and let's jump right into it. You guys hold up your answers for me. Dwayne is a B, Amanda is a B, and Maria is a B. Well, right across the board, you guys all got that one correct. I mean, I would assume that we're giving an effective introduction. You should be using your name. You should be using the patient's name. Also, I found this article kind of interesting. I thought it would bring up a little bit of discussion too, was that they essentially created a rubric in the medical school for introductions and for positive communication skills. And that rubric included an introduction, giving eye contact to the patient, the nonverbal communication, so how our body language is, how we listen, questions. So they were rating medical students on how they asked, like how they did a new patient visit. So how they asked the questions, were they open-ended? The wait time, so how long the patient had to wait. If the doctor was showing concern, the organization of the visit, like was the doctor organized? Were they jumping kind of all over the place? That also leads into the information gathering, like kind of how they gathered information from the patient. The doctor's focus throughout the visit, whether or not they were empathetic, awareness of unspoken issues, and then how they closed that first visit. So I know that was kind of a mouthful, but how do you guys think that you accurately kind of fill all those parts of the questionnaire there, or the rubric that they created?
That was quite a mouthful. I'm not sure I remember every single point, but definitely in the experience of, learning more about patient communication, I'd say that first part, definitely making eye contact, telling them your name. And I think initially when I saw this, I was like, makes them happy. I was like, oh yeah, you want to make them happy. And then I was thinking about all the roadblocks that probably led them there, filling out paperwork, waiting in the waiting room, feeling nervous. And I was like, reduce anxiety. We can't even get to happy until we diffuse the bomb that's already sitting right there. So for me, I think I could definitely work on more of some of the in-between stuff, talking about asking the open-end questions, things like that. Because sometimes you want to get right to the nitty-gritty, but if you know what it is or whatever, but letting them talk, letting them have their moment of reducing anxiety.
Definitely.
I think too, just telling someone they're not crazy. Yeah. We have a lot of patients that come in and they're like, I know this is crazy, but I think it's this. And that moment you get to be like, no, that's not crazy at all. It actually makes a lot of sense. And it could be this or that. But, that for a lot of people are like, oh my gosh, every other doctor said it was in my head.
I know. And some of it's not, they're giving you their symptoms, and some things, it may be more real to them than it is to you. And you need to really, focus on that. They're telling it to you for a reason.
Well, understanding pain, I think that's just, even if it is in your head, it's just as important as if it was on an MRI.
All right, everybody, let's cruise on to question number 2. The article title here is Evaluation of Various Ways to Deliver Information Concerning Non-Steroidal Anti-Inflammatory Drugs to Osteoarthritis Patients. This one was by V. Gurmu and published in the Annals of Physical and Rehabilitative Medicine in 2013. And your question for this one is, what type of knowledge modality helped patients retain information presented to them? So was it A, oral, B, written, or C, both oral and written combined? So we're kind of looking here at like, are patients mostly like verbal learners or like, good listeners, or are they better visual learners, or are they both? Guys are quiet today. I'm calling you out. Maria's thinking really hard on this one.
I am.
It's difficult because I feel as
I'm trying to overthink. I've just gone first.
Yeah, how flattened the art is.
Because I can totally
Interesting too, like as doctors, I feel like, especially the couple of us that are chiropractors and even nursing is so hands-on that I feel like a lot of like the medical minded people are like physical learners or like visual learners. So it's just, this question was just kind of interesting because I would always lean that way.
I was trying to think as a patient when I've been anxious and whatnot. Mm-hmm. What would I want?
All right, let's see what you guys answered. Maria got B, Amanda got C, and Dwayne also picked C. All right, and your answer is C. It was both. So this study, it was a small group. It was 140 patients that they looked at, and the knowledge was improved in all three groups that did, just oral, just written, and then those that kind of got both. But they found that the people that got both retained the most information in both like short and long term. So give your information more than once and the patient should remember it better.
100%. I was just talking about this with somebody, because I think I'm a more like hands-on learner, but in the times where I've been anxious as a patient, I think you're right. Anytime you can text me, email me, say it to me, give me a piece of paper, fly it on a flag coming across. I think that it's going to sink in somewhere because I think we're all nervous and we're all thinking of like, what did they just diagnose me with? And your brain just sometimes or whatever. So yeah, still dealing with that anxiety too, right? So I'm trying to get over that piece. So yeah, even if they don't remember anything I said, I'm hoping that they see my paper and they'll be like, oh.
I think about it a lot with exercise prescription where I'll show someone here and I'm like, you got that? And they're like, yeah, I got it. And forever people would always call the next day like, hey, I don't know if I'm doing this right. So now we always send a video immediately of us doing it and giving them the cues. And they're always like, oh my gosh, I just watched that and follow along.
Oh, that's
so
great.
much easier. And so,
yeah, it's funny you just said that because I was getting treated for my shoulder recently. It was a friend. So you're thinking it's kind of casual, right? I wasn't anxious.
Yeah.
But honestly, with all the different exercises, he just like, give me your phone. And we totally videoed me the entire time because as soon as I went home, I was like, what?
I have kids.
Yes.
That was exactly right.
Imagine a practice where patient engagement is seamless and unified. With trust-driven care, connect with patients across text, email, social media, and Google Business Chat, all on autopilot. Empower your team to step in effortlessly and engage in real time from anywhere. Say goodbye to multiple software and hello to a simplified practice and life. Trust-driven care is the all-in-one solution to save time, boost revenue, and build patient loyalty. Book your demo today and watch your schedule start to fill up. Now, back to the show.
All right, let's check out question number 3 here. All right, this one is titled Use and Meaning of Goals of Care. So it's a phrase, goals of care, in the healthcare literature, a systematic review and qualitative discourse analysis. This one is by Catherine Segunda, and it was in the Journal of General Internal Medicine in 2019. So we're thinking about, what does goals of care mean to you? Your question is, when discussing goals of care, what should the practitioner consider first? So A, the patient's autonomy and patient-centered care. B, the length of care and interventions needed. Or C, the provider's resource needs. So like, what does the provider need in order to reach the goal of the patient? This one is a pretty good, like a pretty large review. They had 214 texts that were included in it, talking about what goals of care means. And I'll give you the definition once we figure out the answer, because it's kind of part of it.
Oh my God. I wondered. I was like, is this just...
Yes. Well, and that's what this whole study did, was they found like what goals of care means most often. So a bunch of different practitioners, they were from different variety of specialties, and the overarching theme of goals of care is what they were looking for. Are we ready? Okay, let's see those answers. Maria's still thinking. We all picked A. Well, I really hope that that's the answer, guys. Yes, it is.
Did you?
So again, we're talking patient communication, right? So we should be coming up with goals, patient-centered. And I will read you the definition that they came up with. It's a little long, but it really kind of surprised me. So goals of care was considered the overarching aims of medical care for a patient that are informed by patients' underlying values and priorities established within the existing clinical context, so their clinical findings, and used to guide decisions about the use or limitations of specific medical interventions. That's big and wordy, but most often the goals of care term was used in patients that were receiving poor prognosis. So most of goals of care are that they were discussing were like end of life care. And another reason why, patient comes first, because having their autonomy for as long as possible is probably one of their biggest goals.
Oh, yeah. That makes sense.
That's interesting.
Just, I know Maria deals with a lot of like Medicare patients in her job as a patient advocate. So I'm sure that this comes up often.
Yeah.
Elaborate.
I think this is...
No, I mean, there seemed to, over the past few years, well, over the past 10 years, probably, actually, there's been a lot more focus on, offices going from just regular medical clinics to patient-centered medical homes. And I know, at least in the military, PCMH, the patient-centered medical homes, are actually a thing. And they're, really trying to bring in, like, how the patient feel like they are the center of their care, and then have the interdisciplinary teams together so that everybody can be on the same page and, just really follow through with what patient wants. And yeah, like in patient advocacy, it's really difficult sometimes. And it's really frustrating sometimes. It seems like, I just talked to Melanie yesterday, and sometimes the message gets missed and the patient kind of gets missed. And that's where they kind of, say, hey, can you, and where I really like to help them out and say, hey, if this is a really frustrating situation, let me help you, because that's what I'm here for. That's what Harry's paying me for. Yeah, I think that, and absolutely autonomy. I deal with patients who are chronic pain, really just very, I don't want to say low quality of life, because it's really the situations that they're in. And it's not because they're not wanting a better life for themselves. It's just the situations that they're, unfortunately, healthcare wise, having to deal with is giving them, not as much of like the quality of life that they want. And so that's really when I hear them say, I quit doing this and this, I quit doing everything I love because I'm just not able to. It breaks my heart. And I'm like, how can we get you back there? Even to just do anything that they love to do. It can change the world. Like it's not even like big things like going on hikes or like some of my patients want to do. It's like, hey, let me feel safe in my bathroom because I passed and I don't feel like my bathroom is safe. So it's like, okay, well, let's look at how we can make your bathroom a little bit safer for you. And just to have those little things happen.
Yeah, and the doctors or provider needs to know that that's their goal. And I feel like sometimes they have a hard time describing that, like, or showing that, like, hey, you know what, I am nervous in my bathroom. But maybe as a, advocate, they're more like, if they're more comfortable, if then the provider is giving that information to you to, pass on.
Well, I think with that one, it just was kind of like and this is how I feel. And it was just very much like part of the conversation, but it was part of the conversation that kind of like winged my ear because I was like, wait a minute, you don't feel safe in your bathroom? Like this is.
Yeah, we should be talking about that.
It's just a state. And, so when we started to do her goals, I was like, you just briefly mentioned this. I said, but it was one of the biggest things that stuck out to me was you're not like, you said that your bathroom is unsafe. Like you feel very unsafe in your bathroom. How can we make that better? So even just like a little thing.
Awesome. Yeah. All right, guys, let's move on. We're going to move into like a different category here that I feel as though we haven't touched on. It's orthodontia. So the title of this article is Factors Affecting Information Retention in Orthodontic Patients. It was published in the American Journal of Orthodontics and Dentofacial Orthopedics in 2008. The author here was Patel. All right, I'll give you the question first and I'll give you a little bit of info on it. Okay, your question is true or false regarding information presented via written paper or computer-based. So it's the same information either on a piece of paper or on the computer. It was found that computer-based information was retained better in both short and long term. So A, true, or B, false. So this was, again, it was a small patient pool, but it was 88 new patients. And they were split into two groups. One of the groups was given commercial information via a leaflet about orthodontic treatment. And then the second saw a computer program with the same information. And they both had verbal information as well, like during their visit. Then an assessment was given via questionnaire. And the participation was great. They did it twice. So the first one, they had 100% participation. And then the second one, it was 67.5%. So 67% was pretty great, I feel like, for a second follow-up.
Yeah.
All right. You guys ready with your answers?
I just answered.
All right. True or false? Dwayne says true. Amanda says false. And Maria says true. All right, let's check it out. It was true, which I actually found surprising too. The computer was better than like having something tangible to take home with you.
Well, it was funny. I don't know. I was going to say, thinking about this, I wonder the age group of people.
That's not when I orthodontic. I'm like, this is young people in business.
And so I was like, but I went with my gut of false, and I was like, maybe I should change it.
Yeah, anyways. Like specifically it was about like retainer use, which could, bleed into that, like, 20s, 30s, even like 40s group. But yeah, primarily a younger pool, and they live on their phone and the computer, right?
You do.
That one was just kind of a fun one. And let's jump into our last question here. The article here was titled Miscommunication in Doctor-Patient Communication. This was by Rose McCabe. It was published in Top Cognitive Science Journal in 2018. And your question here is, the effectiveness of medical treatment depends on the quality of A, the equipment the provider has access to, B, the patient-clinician relationship, or C, the hospital staff available to the provider. Wow, not much about that. Are we like set on our answers, guys? Having effective treatment is, it depends on quite a few things.
Dwayne's ready.
You're ready? Okay. All right. I got from Dwayne, I see a B. Let's see. Amanda's got a B and Maria is a B. Wow. I wonder if this podcast is about patient communication. Your answer was B. So the patient-clinician relationship is incredibly important in the effectiveness of how medical treatment goes and how, patients perceive their doctor. And everything we've talked about today, everything we've talked about over the last 7 weeks. So
yeah.
Important.
I would love to do or see a study also. I've talked about this for a while, but I don't know how it would be done. Patient comes in and I don't actually treat them. I just kind of move their arm around a little bit while I talk to them and really focus on the experience in the office, and then have a survey to see how they feel after and see if you can make someone's pain better just solely from the experience.
A little Dwayne placebo effect.
Yeah.
Yeah, that's right.
I was gonna say, I bet you would get a group of patients though that would feel amazing. Just feeling like you owed them. They felt like my doctor just cares. Yeah. I'd be interested in that study, Dwayne.
I mean, I've had a few, I think at least 2 or 3 of my patients signed up for my company and my advocacy because they didn't feel like they were heard. They felt like they were being dismissed from their providers. And so it's a huge thing. And, then they get frustrated and then they don't know how to go on with the conversation. And then it just ends up turning so bad.
Yeah. How do you talk about,
And they just don't.
how do you talk about like treatment options if you feel dismissed, if you feel like they didn't hear, then you can't
Stop listening.
You talk about how the next doctor you go to.
Yeah. Right? With all,
Yeah.
If you have one, if you have the ability to have one, I mean, some of these states are so small. You're a specialist. There's maybe 2 or 3 practices. And if you've already gone to 2 of them, if there's only 2, then where else do you have to go? You're literally going to have to go to another state if you're even able to get there. If you have
in insurance, like if you're able to afford moving around. Interesting. All right. Well, Dwayne, you are our winner today. Killing it. What organization are you interested in sending your donation to?
Let's do
Oklahoma.
Regionals of Oklahoma.
Okay. All right. Well, I'd like to thank our guests for playing today, and also our listeners for joining us on our own learning journey. We hope that you come back and join us next week for more stimulating information on medical communication research.
Thanks for tuning in to this episode of Trust Driven Trivia, brought to you by Trust Driven Care. Imagine a world where all your patient communication is in one place, seamless, effortless, and on autopilot. That's the power of Trust Driven Care. If you're ready to streamline your practice, check out trustdrivencare.com and see what's possible. Join us next week for more laughs, new guests, and fresh questions that turn medical research into pure fun. Trust Driven Trivia, making healthcare knowledge exciting, one question at a time.